Welcome, everyone. This is the final webinar of the Cognitive Training webinar series. Thank you for everyone for joining the previous webinars. We are excited for today's webinar on the future of cognitive training. I am Melissa Treviño from the National Institute on Aging, and I am part of the steering committee. These are the members of the entire steering committee, and you will be hearing today from Dr. Liz Phelps, who will be our moderator. In today's session, we will have 3 speakers followed by a moderated discussion and then a general discussion. We would love for this webinar to be interactive, so please use chat to ask your questions. Dr. Phelps will ask your question during the general discussion portion. Today's webinar will be recorded and posted online, as well as a summary report will be also shared online. The key questions for today's webinar are what can we do to make cognitive training work better, and what are novel designs that could inspire cognitive training research? I would now like to welcome our moderator, Dr. Liz Phelps from Harvard University. Dr. Phelps.
Hi, thank you, Melissa. I'm Liz Phelps. I'm the Pershing Square Professor at Harvard University, and I'm looking forward to moderating this exciting session. We will have 3 talks. The first will be the future of cognitive training, closed-loop experiences by Adam Gazzaley from the University of California at San Francisco. Then we will hear from Linda Collins from NYU, who will talk about intervention optimization, a new paradigm for cognitive training research. And then finally, we're going to hear from Miia Kivipelto from the Karolinska Institute, who will discuss cognitive training experiences from finger and worldwide fingers, or lessons learned. So with that, I'd like to turn it over to our first speaker, Dr. Gazzaley.
Thank you. Thank you, Liz. Okay, I'm going to share my screen now. So let's hope technology works for me. And I will go into here and press play. Okay. Can everyone see that? That's spinning brain. Yes, good. Okay, let's dive right in. So I'm excited to talk to you about the future. That's where I spend most of my time living. I really like this topic, and I very rarely get to speak about it. But we'll do a quick overview over the next 15 minutes, and I'm happy to answer any questions you have or follow up with you, anyone that's interested in this topic afterwards. So why does it say experience on the slide? Well, and I think most of you on this call and who are doing research in this field believe, based upon your research and the existing literature, that if cognitive training is going to have any meaningful and sustainable impacts on people's cognition, it's through the process of experience-dependent plasticity, which leads to these enduring brain changes. And so if that's true, then we need to think about the experience itself that we're delivering through these cognitive training approaches and how they can be more effective. So that's why I sort of frame this from the perspective of experience. For the last 15 years, I've been working on a very particular type of experience, what I called a closed loop experience. So a closed loop experience, as I define it, is one in which the environment that an individual is interacting with is being updated in real time, ideally in real time, based upon their state in the moment. So what do we mean by that? I'm going to give you a cartoon that I've been using for a long time that really hasn't changed, but then in the slides that follow, I'll give some more details. But the basic idea is that you, and represented here is your brain, is interacting with some digitally delivered experience. And so this could be a video game or, a cognitive task of some kind that you've been hearing about on the previous webinars. But while this is occurring, data from you could be collected that really reflect your state in the moment. And that could be your levels of stress, your emotions, your performance, other reflections of your cognitive abilities at the time. This could use cameras or or your devices itself, like a tap screen, a joystick, any keyboard, anything. And then this data is fed into a processor, represented here on the right by that video game on an iPad. And what's happening there is some type of calculation that is adjusting an algorithm that then feeds back an environment, hold on, that is personalized to you based upon that data. So helping to adapt the sensations that you're experiencing, the challenges and rewards, all based upon that data. With this very complicated data circle, moving from a brain to a computer and then back again, it presents a really interesting opportunity for machine learning. And I'm going to come back to that. So just to be explicit here, it is the mechanics of this closed loop interaction that activates brain networks in a way that we've never accomplished with a drug, for example, or any other type of intervention. It's experience that activates networks selectively, and the closed loop system is constantly applying pressure to those networks to just essentially harness the brain's inherent plasticity to change itself over time. So this is what I have been working on pretty much exclusively in many different ways over the last 15 years, as I said. And I want to give you just one example from our work that actually covers this whole 15-year range. I tend to think about this not necessarily, I don't really call it cognitive training, although I don't think that's an inappropriate term, but I really try to put the emphasis on the experience. So I think of it as experiential medicine, has that promise at least, and in this case, digitally delivered experiential medicine. So for me, this started 2008. It actually wasn't Neuroscape at the time. It was my lab, Gazzaley lab, and at UCSF. And I designed and then developed with video game experts at LucasArts a game called NeuroRacer that was based upon our research on how we can challenge cognition, cognitive control specifically in older adults to lead to transfer of benefits. 5 years later, after a ton of work, 3 studies finally published this in Nature in 2013. And what we showed there that we were able to lead to benefits outside of the game in terms of working memory and sustained attention, and also show with neural recordings what mechanisms of action of these transfer effects are, and then some degree of sustainability of some effects. Now, this wasn't a perfect study. We've increased and improved our methodology since then, but there were 2 control groups here. And I think, if anything, this was a blueprint of how you might have scientists working with experts in a different industry, video game professionals that are artists and musicians and storytellers and have high expertise in usability, to design a cognitive training intervention that was elevated in terms of its experiential aspects, but then bring it into the lab and do a well-controlled study to understand what its impacts are. And jumping ahead another 7 years later, with the addition of a company, I guess I'm disclosing that now, probably should have done on the first slide, a company called Gazzaley, which I'm a co-founder of. We moved this technology out of Neuroscape and created a much better closed loop video game that has now achieved 3 FDA approvals. One as a treatment for inattention in children with ADHD, another for adolescents with ADHD, and now FDA approval for adults with ADHD. So based on different studies, making it the first ever cognitive training intervention, or for that matter, video game, ever approved by the FDA for a clinical condition. So we're super proud of it, but I could tell you it is still very hard to commercialize something quite as novel as a video game that requires a prescription. So there's a lot more to talk about there, but in the context of this, of thinking about the future of training, the lesson is here is that you can take a mechanic that existed back in NeuroRacer and bring on very high levels of art, music, story, usability, reward cycles, to create something that people engage in more deeply in the moment and more sustainably over time. And although it doesn't have to be a video game, I'd say that there's a lot of benefits to fun and play, and humans value those aspects quite a bit. So where are we now? How do we step into the future beyond what I just told you that we've been working on for the 15 years? Well, there's a unique opportunity right now in that there is an explosion of new experiential technologies that allow us to do so much more than I just described to you. And you are familiar with these. It's the advent of commercially available virtual reality, augmented reality, motion capture, wearable physiological recording devices, and of course, AI, both in the machine learning capacity that we've already had a lot of experience with, but now the generative AI world. So how do we leverage this, which is largely being used for communication, and entertainment as tools to help us improve our cognition and increase our ultimate goals of helping people have better minds, right? How do we do that? So we work on this full time at Neuroscape. This started as my lab, but it is a center now. We have 12 faculty, 45 people. These are 4 of our 8 labs. And we're really dedicated to trying to figure out how we can integrate these advances that I just described to you in technology and more that I'll tell you about in a moment with basic neuroscientific principles as well as rigorous randomized control trials. That is what we try to do as we move into the future. So one other thing that I will emphasize, and this is not just meant to be a review of our work, but again, a focus on the future, is that I see a lot of value in creating cognitive training approaches, or however you think about this, that really sort of target as close to possible as real world experiences. So what you're looking at here are 3 games that we have been working on over many years, all built in-house at Neuroscape. Labyrinth, which is where you navigate a virtual world with a head-mounted display. Coherence has both a tablet and a VR version, which is a rhythm game that is adapting the rhythmic challenges based upon your accuracy, your precision, and your consistency. And Body Brain Trainer, which takes place with motion capture using physiological recordings as well as your performance data to guide the feedback. So all of these games have in common, and everything we've ever built, is that these are closed loop experiences designed to challenge different aspects of cognition. So they're not classic cognitive tasks per se, but they are supposed to do so in an engaging, fun, rewarding way. But the point of this slide is that we believe, and now we're testing that you can get more benefits, maybe more enduring benefits, maybe even quicker benefits by more immersive, sensorily immersive environments, and I'll show you where we're going with that now, as well as by having people move in as real world ways as possible, rather than just tapping with their fingers or tapping on a keyboard. And you could see the list of publications over the last several years that have validated this in the in Neuroscape, largely for older adults, but some work with children as well. And if you go to Neuroscape website, you can see, and find all of these publications if you want to dive in a bit. I also want to talk about the potential to not just think about interactive, challenging training tools, as I just described. All those have in common that they are exhausting to the participants, so we need to take frequent breaks. But I am now really interested in passive experiences and their roles in improving cognition, emotional regulation, stress, sleep, other things that fall into the the overall picture of what makes a person have a healthy mind. And so nature and music are perfect examples of this. And we have many studies, at least 4 studies, that are focusing on the role of digitally delivered nature experience and music that are not being coupled with challenges, but still can have adaptivity and still be closed loop in terms of how the environments are changing. That lab in your upper left corner is our new sensory immersion lab, and the point here is that we can go beyond what we typically think of as VR delivered through a head-mounted display. And so that is a sensory immersion lab that we built during COVID when our research was shut down, as it was for many of you. And that is a 1-person laboratory where you see, hear, smell, and feel experiences. And on the right is one of our nature experiences that we developed working with a videographer and artist, Louis Schwartzberg, and a musician, East Forest. You can see my daughter's not actually a participant in this study, but is captivated by this type of journey. So the point of this slide when thinking about the future of cognitive training is sensory immersive environments and building them out with real experts in the field that create really compelling experiences. 2 points over here. One is that we can be feeding neural data and other types of physiological data into these closed loop systems. It just doesn't have to be personal performance data. And we have several papers in this regard that you could refer to. One by Jyoti Mishra in Journal of Neuroscience showing that neural data can be used to enhance the closed loop system beyond performance data, that's EEG data. And then 2 papers by Joaquin Anguera showing that that physiological data collected with a watch, this is in the body-brain training intervention, can be used to feedback not just challenges in the cognitive domain, but physiological. So in this case, the physical challenges were being adapted in real time based upon the player's heart rate, which was fed into the closed loop system. So those are two examples, and I think a really important future direction is getting more creative with how data beyond performance data, which is the most accessible data, can be fed into these systems to lead to greater effects. The other things we can do is to use data to guide other approaches that might enhance those effects. So for example, non-invasive brain stimulation, we have a whole series of publications showing that we can use transcranial direct current and now more frequently alternating current stimulation to increase learning curves, at least in the moment. Where we would love to go with this is bring this into a closed loop design where neural data and other data can be used to update the stimulation parameters to create more personalized targeting. So this is a lofty goal. It is actually very technically challenging to both be recording and stimulating at the same time, but this is our intentions. And so I just put this slide up as two future directions for the field to be integrating more complex signals into closed loop experiences, and then to be coupling these with other approaches like non-invasive brain stimulation, which in itself does not have the ability, when applied non-invasively, to activate brain networks very selectively, but when coupled with an experience, you can get a synergistic effect, and that's the promise of combining technologies, multimodal interventions. All right, multimodal will be the theme for the rest of this talk. Multimodal biosensing is another big idea for the future, and it's something that was also a big focus of us during COVID when we were building and not doing research. So we created what we call the DREAM system, a multimodal biosensing system that doesn't just record brain activity, but full body activity, and you could see it designated here. I'm not going to dive into this, but we record 180 electrodes worth of data in many of the studies that we're doing now, with the idea that a more comprehensive view of someone's physiology, not just brain but body, might be more effective way of guiding closed loop systems. So to put this all together and conclude, where we are heading is that multimodal biosensing is capturing more detailed, real-time, comprehensive information about a person's state, using that to change a multisensory immersive environment, leading to an opportunity to use machine learning, what we're calling here interpretive AI, to understand that data in real time, and then the opportunity to use generative AI to create these immersive environments, which gives us great potential to leap into the future. And so I'll conclude with this vision of experiential medicine being the future of cognitive training, where we're integrating closed loop adaptive experiences with multimodal biosensing, multisensory immersion, and then the opportunity to combine this with currently existing medicines like molecular treatments, which don't have the real targeting to networks, but do increase overall activation. And we're now looking at one particular molecule, psychedelics, to see can we combine that with this closed loop experience to create closed loop psychedelic treatments, which we think could have great benefits across a whole array of clinical populations. And with that, I will close over there and pass it on to the next speaker.
Thank you so much, Adam. That was fascinating. We have lots to think about. We're now going to move on to Linda Collins from NYU, who's going to talk about intervention optimization, a new paradigm for cognitive training research. Linda, take it away.
Hello, it's really nice to be here. And wow, that was a very interesting presentation just now. Let's see. Okay. I'm going to be talking about a methodology, a paradigm, intervention optimization, which is a different way of thinking about developing interventions from what you're probably accustomed to. So here's an overview. I'm going to be talking about very briefly, what is intervention optimization, why I might want to consider intervention optimization, how can I optimize a cognitive training intervention, I'll make a few comments on the overarching themes of this webinar and give you some pointers for how you can learn more if you're interested. And of course, I hope you will be. So what is intervention optimization? Well, in a nutshell, it's a new paradigm for intervention research. So let me define what I mean by optimization in this context. We define intervention optimization, by we I mean those of us working in this area, as the process of achieving a strategic balance of intervention effectiveness, affordability, scalability, and efficiency. I want to make the point that intervention optimization is not about finding the absolute best. Instead, it's about finding the best you can actually use, the best you can actually use. So the absolute best, most people would say, would be the most effective intervention, but the optimized intervention is going to be the most effective, subject to realistic constraints on things like willingness to pay, that is, how much whoever's going to pay for it is the intervention is willing to pay, how much staff time is available, a tolerable level of technological complexity, the amount of time that participants have, and so on. So because those are kind of limiting factors, it's necessary to balance effectiveness against affordability, scalability, and efficiency. Now, why might I want to consider intervention optimization? Let's take a look at business as usual, which is the classical paradigm for intervention development. And those of you who develop interventions, you're used to this. This is just kind of a schematic of it. So the intervention scientist identifies some number of components. I've got 5 here. It could be any number of components. They are perhaps pilot tested, and then they are assembled into an intervention package, which is represented here by this box or cube. And then that package is brought to an evaluation RCT. That's an experimental design we're all familiar with. Usually there's 2 experimental conditions or arms, and participants are randomly assigned to receive either the intervention or some kind of suitable control or comparison treatment. And I want to point out that when the intervention is being assembled, when those components are being assembled into the intervention, there's no consideration given to selecting components to balance multiple considerations at all. In fact, once they're identified there on the left side of the screen, it's a foregone conclusion that they're going to make it into the intervention. So hold that thought and let's discuss some objectives of the cognitive training field. Well, first, I think the field would like to build a coherent knowledge base about what cognitive training strategies work, who they work for, why they work, to improve cognitive outcomes. Second objective is to use this knowledge to develop interventions that have an immediate public health impact on cognitive outcomes. And then another objective is to just keep making improvements in these interventions over time so that they get better and better. Has the classical paradigm helped the cognitive training field to achieve these objectives? First one, developing a coherent knowledge base. Well, if you use the classical approach, when an intervention demonstrates a detectable effect, it's not clear how or why it worked because all of the components are included in the treatment, not included in the control, so they're completely confounded. When an intervention does not show a significant effect, it's not clear why it didn't work. That's very frustrating. And so the conclusion here is that we're not making good progress toward developing a coherent knowledge base about what works and what doesn't work. The second objective, immediate public health impact. Many interventions developed today end up being too expensive, complex, or burdensome to be broadly scalable. We've all seen that. Think about how many interventions you know of that have been developed in academic settings that ever go to scale the way they are intended to. Well, one thing you could do, I suppose, is, and this is done sometimes, you could remove some components to make the intervention more manageable, more economical. But without a method for achieving a strategic balance of effectiveness against resource utilization, you really can't fix this, and you run the risk of removing components that are critical for the effectiveness of the intervention that was observed in the RCT. So the conclusion here is that we're not successfully achieving immediate public health impact. Improvements, well, we're unable to determine which are the strong and weak components in an intervention. So any next steps to make improvements are unclear. We could develop next steps if we knew where the weak points were, but we don't. So it's hard to know how to move forward. And the conclusion is that we're not set up to make ongoing improvements, and therefore we don't have much hope of achieving objectives 1 and 2. Now, meanwhile, in other fields, things are quite different. Let's take a look at some consumer products from the late 20th century to today. 30 years or so of progress. Flip phones from the mid-1980s, I think you all remember how aggravating they were. If you wanted to send a text, you had to press several times. Today's phones are really great, and sending texts and talking to people is like the least that they do. I was a proud owner of a compact portable computer. This is one of the first computers that you weren't chained to your desk to use. It was portable in much the same way a small refrigerator might be considered portable. And now we have these really sleek, light laptops you can just stick in your purse or briefcase and go. This is a BMW 3 Series from that era, 21 miles per gallon, no airbags. Today's BMW 3 Series, much more fuel efficient and airbags all over the place, much safer car. These are very different fields, but one thing they have in common is that optimization is fundamental in all of these fields and many others. And I'd like to suggest that that's one reason why they've made so much progress. So how can I optimize a cognitive training intervention? Well, those of us working in this area suggest using the multi-phase optimization strategy, abbreviated MOST. And this strategy is an integration of ideas from a number of different domains. Of course, behavioral science, bringing in evidence-based strategies. Another is industrial and control engineering. We've borrowed a lot of ideas from industrial and control engineering. The principles of optimization come from there. Health economics is all about management of resources and making those difficult trade-offs. Decision science, again, making difficult trade-offs strategically. And of course, implementation science, methods for achieving implementability of interventions. This is a schematic of the multi-phase optimization strategy, so you can see it in a little more detail. I'm going to walk you through it. You see that there are 3 phases: preparation, optimization, and evaluation. These are the 3 phases. Preparation and evaluation, you are similar with a lot of what goes on in those phases already. What's going to be different for you is optimization. So let's walk through them: preparation, optimization, evaluation. The preparation phase, the purpose is to prepare, lay the groundwork for optimization. This requires deriving, or in some cases revising, a conceptual model. This conceptual model should be theory-based to the extent that that is possible. Sometimes people are working in a brand new area and there's not much theory, but in general, most of the areas we work in, there's a lot of behavioral theory, and that is the basis for the conceptual model. Maybe several different theories are integrated. The investigator identifies a set of candidate intervention components. I'm calling them candidates because they're candidates for inclusion in the intervention. They're going to be tested in the optimization phase. Any pilot work is conducted in the preparation phase, and the investigator also identifies an optimization objective. This is your operational definition of what you mean by this strategic balance. So for example, an optimization objective might be, I have determined that whoever is going to pay for this intervention, perhaps an insurer, is willing to pay up to $500 a person. So I'm going to identify the set of components that gives me the most effective intervention I can get without exceeding that cost, that upper limit on implementation cost. Many, many different possibilities for optimization objectives. That's just one example. Then in the optimization phase, you would build the optimized intervention. And here you conduct an optimization RCT, which is different from an evaluation RCT. They use different experimental designs. They have different logic. And the idea, the purpose of an optimization RCT is to assess the performance of individual intervention components, and depending on the design, whether they interact. Factorial experiment is a very common optimization RCT design. Sequential multiple assignment randomized trial, which many of you may have heard of. There's lots of hybrid designs out there that combine features of these. and MRT, the micro-randomized trial. And there also is something called a control optimization trial that is kind of comes out of a different tradition from those others. Comes right out of control engineering. Once the optimization RCT has been conducted and you have data, you use the data to decide empirically which combination of components best meets the optimization objective. So for example, the optimization RCT will tell you which components are working and which ones aren't. So you can use that as a basis for selection. It will tell you whether the presence or absence of one component has an impact on the performance of another component. That's another piece of information that is helpful. And then you would move to the potentially move to the evaluation phase, where you can confirm the effectiveness of the optimized intervention in an evaluation RCT. In the optimization phase of most, investigators address questions like, is the inclusion of a particular component worth its cost? What combination of components delivers the greatest effect while requiring no more than a total of, say, some number of hours of participant time? If treatment A is not working for a participant, what should be the next step, staying the course or trying treatment B? If treatment A is working, what should be the next step, staying the course or a reduction to a lower level maintenance treatment or perhaps no treatment at all? Should treatment vary by context, and how? And when component A is delivered digitally, is its performance comparable to when it is delivered by a human? Those are just some examples of the kinds of research questions that can be addressed in optimization RCTs. Most can be used to optimize an intervention the way we usually think of interventions, but also we take a very broad view of interventions. The delivery of an intervention can itself be considered an intervention. You might be interested in optimizing what we often call a wraparound intervention that is kind of wrapped around a particular intervention to encourage adherence or engagement in that intervention. And of course, intervention implementation can itself be optimized using this approach. I just want to make quick comments on the overarching themes. Scalability, most is all about developing interventions that are scalable before they're brought to an evaluation RCT. That's an important part of what this is all about. Reproducibility, by scientifically examining the performance of intervention components in carefully controlled, fully powered, randomized experiments. We believe that that moves us toward more reproducibility in terms of what works and what doesn't work. Generalizability, that's a term that can have different meanings in different contexts, but there's an interesting idea from engineering, plant friendliness, where you develop what we would call an intervention, what they would call something like a chemical reaction or something like that. You develop it specifically so it works across all the plants, and it's not quite as good for any particular plant as a tailor-made procedure would be, but it has the advantage of working across the board. So I've always thought that was an idea that could be applied in intervention science. Intervention equitability, we're doing work in that area, optimizing interventions for equitability. That's an article that appeared recently in Prevention Science about that. And best practices and future directions. There's a lot to say about that, but I just want to say that this is a kind of a wide open area, very active right now with a lot of new methodological developments all the time. How can you learn more? This is the current go-to article in the annual review of clinical psychology and this year, if you're interested. Do not buy these books. You can download PDFs for free, probably from the Springer portal at your university library. The one on the left gives a comprehensive introduction to most. The one on the right is a chapter book, an edited book that covers some advanced topics. I direct a center at NYU called the Center for Advancement and Dissemination of Intervention Optimization. We have a partner center at the University of Michigan, the D3C Center. We both offer trainings, lots of online information. I recommend checking out our websites and subscribing to both e-newsletters. We don't clutter up your mailbox too much, but there's a lot of interesting activities going on all the time. We just joined forces on a one-stop shopping website that provides an introduction to intervention optimization. So there's a QR code there for you if you like that sort of thing. And that concludes my presentation. So thank you.
Thanks so much. That was so useful and interesting. I will not buy your books, as you suggested.
Good.
I'm going to now move on to our third speaker. Miia Kivipelto is going to talk about cognitive training, experiences from finger and worldwide fingers, or lessons learned. So, Dr. Kivipelto, take it away.
Thank you so much. My slide show, yes, now it works. Thank you for the invitation. I'm very happy to be here and talk about cognitive training as part of the multi-domain interventions and, as said, experiences and lessons learned from finger and worldwide finger studies. And we all know that there is great interest for modifiable risk factors, and that field has been advancing very quickly. The most recent Lancet Commission paper is suggesting that at least 45% of all dementias are linked to modifiable risk factors. Last time when the paper came out, the number was 40%. So this list of modifiable risk factors is increasing. Education is one of the risk factors listed here, but as you can see, cognitive training or cognitive stimulation activity is not there. Of course, some of the risk factors or protective factors like physical activity and many lifestyle factors, of course, can also include cognitive activities as well. So there is a lot of interactions between different risk factors. We already heard that the cognitive training, the evidence is mixed from both Linda and Adam, where we are in that field. We know from some trials that cognitive training is linked to benefits among people at risk of dementia, but the trial evidence is mainly low quality, and there has been a lot of heterogeneity in the evidence. So it has been quite difficult to really understand the methodology and take the lessons learned to the next level. At the same time, I'm thinking, as we already heard, there is so much new evidence about what is happening in the brain, how our activities is affecting the brain function, brain structure. We can visualize with the new methods and imaging what is happening in the brain, and the concepts brain and cognitive reserve have been moving on. But as I say, there is no golden standard to one specific type of or dose of cognitive training. And as we discussed, the transfer effect and long-term benefits have been a bit unclear. And the trials which we have been reviewing and working with, cognitive training has been done in different ways. It can be pen and paper or using more digital cognitive training, both web-based and apps. And I really believe that digital solutions have multiple potential benefits because the level of difficulty is more easy to adjust, and also the progress level that is getting more and more demanding is scalable, and it can be more easily kind of followed and automatically recorded. In the finger trial, the idea was that we are not only focusing on one of the modifiable risk factors, but we wanted to target several risk factors at the same time to get an optimal preventive effect. So that's the concept of multi-domain interventions. And that was the first study really showing that it's possible to prevent cognitive decline using these multi-domain lifestyle-based interventions. Persons were between 60 to 77 years old, and they came from general population. They had increased risk of dementia based on GAID dementia risk score, meaning that they had some modifiable risk factors, and low education was also one of the risk factors included. But cognition was at mean level, so we took away persons who had clear cognitive impairment and those who had perfect memory. And here you see the multi-domain components: nutrition, exercise, cognitive training, social activities, and taking care of all vascular risk factors compared to regular health advice for 2 years. We have been conducting extended follow-ups up to 11 years, and that's important to learn more about the long-term benefits of this type of intervention. Many of you may know the main results from the finger study. We could see cognitive benefits. Global cognition was the main outcome, 25% more improvement for the finger group. And we saw the same pattern for all pre-specified cognitive subdomains. Executive function, 83% more improvement, processing speed, 150% more improvement, and memory, 40% more improvement. And as we know, all these domains are so important for independent daily living. So this is not only reducing the risk of cognitive decline, it's really optimizing brain health. Interestingly, I often got the question, how about if you have a risk gene, ApoE4, can you still do something with multi-domain lifestyle intervention? And we have now evidence, not only from finger, but also a study from Japan and France, that actually it seems that ApoE4 carriers are getting more benefit of this, which is of course very, very optimistic finding. On top of the cognitive benefits, finger model could give many additional other benefits: lower risk for cardiovascular events, better functional decline, better quality of life, and even health economical benefits. And I was thinking what Linda mentioned about this public health and implementation. This is, I would say, one reason why this multi-domain intervention package is now highlighted as a possible way to really move on, not only for the brain health, but also more for the total health. How was then the cognitive training in finger? We had a lot of discussion when we started the finger trial. Should we use the paper and pen, or should we go to the computer-based training? And you need to keep in mind that finger started already 2009. And at that time, it was more common, I would say, to use still the paper and pen. And I'm very happy that we dared to go to the computer and web-based solution that was developed by our study collaborators based on our some smaller scale studies which were showing shorter term benefits in these trials. And the domains which we trained was mental speed, working memory, executive function, and episodic memory. There were totally quite many sessions, but it was 6 months, 2 times during these 2 years, and 3 times per week was the recommendation. And the optimal level that was adjusted, and it was increased over the course of the study. How was the adherence? Well, it was lower compared to other domains, and that was what we expected. Quite a lot had something to do that people were not yet so get used to use computers. Not all older people had even their own computer, so they came to us, to the study center, and we helped them to do the training. There was a great variation. 63% participate at least once, 20% half, and 12% did all the sessions. And we could see some factors correlated with the higher adherence. For example, as could be expected, previous use of computers, kind of positive expectation of the study, better memory, and so on, younger age as well. And in general, higher adherence to cognitive training was associated with better cognitive slopes during the 2 years of intervention. So there was a clear link between these two. And the question is, of course, what is the dose? Can we say something, how much training you need to do to get the benefit on the brain health? Here we have the results for all 5 fingers, and we could see a quite nice dose-response relation. So that those who did at least 50% of the training, we could see the clear benefit for the brain. So luckily, you don't need to do everything, but there seemed to be some clear cutoff. And of course, supporting the more long-term adherence is important, both in our trials and in the implementation. If we look more specifically, the cognitive training part, we could see a change in condition, change in cognition according to the intervention adherence. And interestingly, it seems that the adherent person, here we use the same 50% cutoff, we could see benefit for all these cognitive subdomains which I showed. So these are the results for cognitive training. After the finger trial, I got the question actually from our patients at Memory Clinic: is it too late to do multi-domain intervention and cognitive training if you already have early Alzheimer's disease. And that's why we conducted a smaller pilot study called MindAD, adapting the finger intervention for those persons who had early Alzheimer's disease. And adherence, as you can see here, for all 5 fingers was good. And even for the cognitive training, actually, it was higher here compared to finger. But we need to keep also in time that this was later, this was younger and more educated population. And it was important to adopt the cognitive training because it was a bit too difficult when we started that, and the participants felt that a bit in a negative way. So we needed to do some adaptations during the study to adopt the cognitive training level. And very interestingly, already after 6 months, we could see that this whole package gave many positive effects, and also CDR sum of boxes summarizing cognition and function. That level was better in this multi-domain group. We have not been yet specifically analyzing the cognitive part, but that's something we plan to do. And this gives me the encourage to say it's never too late. In general, lifestyle interventions, the effect is not ending the time you get the diagnosis. You just need to do some more adaptations. After the finger study, there's been a lot of interest globally to adopt and test and optimize the multi-domain interventions for different populations and different settings. We initiated the Worldwide Fingers Network 2017 to support these countries and also try to harmonize the protocols so that we know, for example, what the cognitive training is so that we can more easily conduct a joint analysis. And I'm very happy that today we are having 68 countries as part of the network. And you can see that many are actually low middle income countries. And we are having already now 20,000 participants as part of the trials, and many are in the planning phase. During the pandemic, there was a huge push to start to use more technological solutions, both in the cognitive training, but also measuring the activities. So the concept e-fingers and even AI fingers has been developing a lot during the last years. And we also have been doing some measures. I believe really that the e-based and digital kind of training ways is the future. Internet access is not anymore the barrier. 63% of global population were using internet 2021, and the rate is increasing very rapidly. Nordic countries where I work has very, very high level. I don't know the numbers, especially in the US, but these are the global numbers. What do we know then about the cognitive interventions as part of the Worldwide Fingers? Well, here is a list of some of the web-based digital programs we are using. So there is no one solution for all, but as I mentioned, we try to capture what is going on so that we can then compare the results. And quite interestingly, what I think is important is most trials are also using group sessions. So it's not only digital cognitive training. And some trials are having both pen and paper options to replace digital training if needed. And this is just at the end, one nice example from Mind China, where we conducted and we are conducting the trial at the rural area. So they are using a computer-based cognitive training, a training that is called the 66 brain software, 3 times per week, 20 minutes each time. But they also are having personalized intellectual activities, for example, paper cut material and playing cards. Here you can see some photos. And this is the one I especially like. It's a nice combination of the cognitive training, social interaction, because the participants are coming to the study center. And then you can do also more this traditional cognitive training adapted to that culture and that setting. And finally, just a few reflections. How can we facilitate cognitive training in different settings? I hope and I believe we can learn a lot from Worldwide Fingers. We can try to use several alternatives for delivery. smartphones, computers, doing it individually or coming to the study center. Very important to give guidance and follow up, learn how to use and do the training and giving reason why this is important, support motivation. And also, as I already said, training program adapted to the target population seems to be very important if you want to have the long-term adherence. And I believe, as I said, that digital cognitive training is feasible, given the factors that access to internet is increasing so rapidly. And also intervention can be combined with group and individual coaching to really make it more feasible. And at the end, I have just one slide about the implementation. It takes normally 15 to 20 years to start to implement our research findings. I think it's too long time. So maybe even though our evidence is still developing, we should start implementing the cognitive activities. And this is something we do now in the Nordic countries. We try to implement finger at different levels, memory clinic, brain health clinics, primary care, and municipality level. And it's not only cognitive training as a program, but more education, lifelong learning, occupational working life activities, and leisure activities as well. So taking this as a one package. And at the end, just my final comments. Cognitive training as part of multi-domain intervention seems to be effective and visible. It's never too early, never too late. We are moving towards precision prevention, and I believe cognitive training should be further studied and optimized for different target population, and focusing not only on dementia prevention, but brain health, implementation, and global strategies. And at the end, I want to thank all my colleagues at different institutes, and I want to thank you for listening. Thank you so much.
Thank you, Dr. Kivipelto. That was fascinating. We're going to move on now to the moderated questions. So these are questions from the steering committee, and then after that, we'll open it up to questions from the audience. So these questions are for all the speakers, but jump in if you feel it's most appropriate for you to answer based on your expertise or presentation. So the first one is that some of the newer interventions we've seen are quite complex, involving data from neural signals and various sensors to tailor the intervention to each individual. And while this may enhance effectiveness, it also raises additional barriers to engagement and challenges related to long-term adherence. So how do you envision this work being implemented more broadly, and how might these barriers ultimately be overcome? And I think, Adams, your presentation, sort of leads to that question, but I know Linda and Miia, probably have some good insights as well.
Sure, I'm happy to start off the discussion on that. The first pass on figuring out how to move from the lab into people's lives, I think, really has to heavily rely on technology that everyone already has. So phones, tablets, phones even more so than tablets, not just Apple phones, but Android phones, and just meet people where they are with the technology that they have, and find a way to produce some benefit that extends outside of what we might find in a randomized controlled trial, but actually has meaningful benefits in their lives. So this is already a tall order. My fellow speakers really pointed out a lot of the challenges and opportunities, but we haven't really gotten there yet. So that has to happen. But the role of other signals that could have either neural signals or even activity signals from a phone, or sleep signals from a ring, passive measures as opposed to active measures, that's the future, I believe, because it's going to give us a type of granular detail that will allow us to do more than actively entered information will do alone. So our strategy is to push into the future in a way that unfortunately is not very translatable to most people right now. Keep doing the work to understand how the tools that we have here can have benefit, And then the hope is that those worlds collide, but it might not be even till 5 or 10 years as devices become more and more accessible and affordable and sensitive, and more systems are put into place to get meaningful data. I think there's an important use of AI here that hasn't been realized yet. Then we've done the work with the tools that people have, and then we could integrate it with these future signals and devices to lead to better value. That's how I sort of think about it.
Dr. Collins, Dr. Kivipelto, you want to add anything to that?
Yeah, I'd like to comment. There's a couple different sources of complexity I think we could tease apart. One of them is, having a lot of sensors or devices or a lot of kind of streams of measurement. And I mean, that I don't see that as that much of a problem. I think for the reasons that Adam talked about, like he's out ahead of it right now, and that's only going to get simpler over time. So that I don't see as an issue. What I think is an issue in intervention science is, and I want to preface what I'm about to say by saying that I'm not talking about the work of anyone specifically, and I'm not talking about the work of my fellow panelists, or I just want to make this comment as a general comment about intervention science. The classical paradigm does not encourage any kind of restraint about the complexity of interventions. It's all about getting a significant effect in that evaluation RCT. And so people who've been developing interventions have put a lot of components into interventions, because it's if you're not sure what's going to work, you put everything in, and because you want to get that significant effect. And I feel like we're paying the price for that, because people don't want to do participants don't want to do long interventions. They drop out. People, I think, after a while have a sense of what's working for them and what isn't, and get discouraged about doing stuff that's not, having any benefit for them. So, obviously I'm a proponent of intervention optimization, but I often say if I could get just one thing, it would be for people to take seriously the idea that we should be removing dead components from interventions.
Yeah, I fully agree with what you said. And my experience is as well where we are new technology can really help if we want to move to these personalized, individualized interventions. And also people normally like it. They get also feedback what they are doing. And for the components, I said physical activity, blood pressure, these are more easy interventions because we have been able to measure it many, many years. But cognitive training, what is happening in the brain, we start now to have these measures, and it's motivational to persons as well to have it. And also selecting tools, as you said, mobiles that is more easily available. Passive monitoring is coming more and more. And then, of course, the critical step when you go from trial to implementation, then you may need to think what is possible and what is meaningful. And maybe one size does not fit all. You may have a toolbox of tools which can be used if feasible. So that's what we have been doing in our municipality level. We are not taking everything what we had in finger. We take the measures which we believe is feasible in that setting.
Okay. So staying on the topic of personalization, so ideally intervention optimization and personalization would be tailored to specific gains and individual experiences under the current intervention parameters. But how might this best be implemented in the domain of cognitive training, given that the timescale between administering an intervention and observing benefits could span years or maybe even decades, as seen with some of the sleeper effects in the active trial? Does anybody want to start with that one?
Yeah, that's often an issue with intervention optimization. If the effect, if the time, I call it the time horizon of the effect that you're looking for, if that's way off in the future, that does create a challenge for intervention optimization. You ideally would like to optimize on the ultimate outcome, but you can't always do that. I didn't have a chance to talk much about the conceptual model, but most interventions are developed to have an effect on a mediator, and the mediator in turn, or a chain of mediators, affects the outcome, the ultimate outcome. And so when the time horizon is far away, you can optimize based on measures of the mediators, but you have to have good measures of the mediators. But that would be my answer to that question.
I think, of course, my field is a lot of dementia, has been dementia prevention, and that has been discussed so much. What is the clinically meaningful benefit? If you get benefit on some cognitive domain, what that really means. And of course, dementia is not feasible outcome if you start so early, so you need to have proxies. And we are now talking more and more meaningful benefits, not even clinical significance, because when you start among at-risk population who have no cognitive impairment, what is clinically significant is kind of, so I think the whole field and the old definitions from dementia trials, we need to rethink of that when we start earlier and earlier. So the concept meaningful benefits and having some proxy for something else, I think is very, very important.
Dr. Gazzaley, you want to add anything?
Yeah, I like to think of this in the same way that I think about game design. I learned a lot by working with game designers over the last decade, and they tend to approach, for example, reward cycles as an onion. That's what they call it. So reward cycles, which is similar to this, can have a role at all different time scales. So there's the immediate that just create that deep engagement and constant, powerful cycle, the closed loop that I was really talking about. Then there's medium time scales and long time scales. And the long time scale rewards are better at leading to like longer, more sustainable changes, like your characters being updated. It doesn't happen every moment, but it makes you want to come back again and do it again. And I think it's the same thing here, in that the approach, and I certainly don't have all the answers here, but the approach that I like to think about is sort of how adaptivity and personalization can occur across these different timescales. So there are the immediate ones where you're giving people that quick feedback and adaptivity and personalization that makes it fun and not too hard, and that has lots of immediate value. But then there are, of course, the bigger long-term adaptive loops that lead to, behavioral change and other things. So I like to just think about it as an onion across different timescales, and they're all important, and they all have different mechanisms of approach. So that's
Can I just follow up on what Adam said? I love everything that Adam said just now. And I just want to comment that I think a slightly different way to put that, a more traditional way to put it, would be that it's really important to have a clear conceptual model when you're going into this stuff. And something that's left out of that a lot is time. We don't very often include how quickly a process is unfolding in our models, and that we should. We all know that different processes take some are fast, some are slow, and we don't include that enough. Billy Namshani at the D3 Center at Michigan is working on that issue of time in time-varying adaptive interventions. Very, very interesting stuff.
Okay, so we've heard about a bit about in this webinar series needs for integration of measures of mechanisms into our trials, but it isn't still entirely clear where the highest priority places to start is if we want to adopt a systems neuroscience approach for understanding cognitive training moving forward. So even at the measurement level, it's not clear how should we be thinking at the neuroscience level, or which measures should we have if we want to integrate into trials moving forward to produce deeply phenotyped and characterized patients across a spectrum of spatial and temporal scales moving forward. So what are the needs and opportunities to nudge the field to more broadly explore and adopt systems of cognitive neuroscience approaches? Anybody want to comment on that one? They didn't come up too much.
Yeah, I could speak a little bit to that, because I started as a cognitive neuroscientist. I still think I am to some degree, and we do a lot of cognitive neuroscience in parallel, sometimes integrated, sometimes not, with our intervention studies. And the way I think about it is that we can integrate them better. So there are studies that you can do only in a laboratory, where you might have an MRI scanner or very detailed testing that need diodes attached to them to get perfect timing, and really the level of rigorous experimental design and methodology that is perfect for a laboratory to answer, deep cognitive neuroscience questions. but they can answer other questions that require large numbers of people from diverse places and, you know, things of that nature, because no one could afford to do those studies. So they're equally important, and they're both tapping at the same type of goals of understanding how we make change so that we can iteratively do it better. They just do it through different mechanisms. One through this very deep dive to understand how, you know, neuroplasticity works and what are the individual differences, and the other that really addresses the diversity and, you know, question and has the power to answer things like real world impact, which you could never do with a small randomized controlled trial. So they're both great. We have poorly integrated them together, we as a field. And I get it, because, like, you know, there are different types of researchers, different types of training that went into it. But I've always been very excited. And when I talk to epidemiologists about this, they seem excited too. But the idea is you could do large scale trials, and then part of that study are taking samples of it and bringing it into the lab, and then using that deeper dive data to reflect back onto the large population data. So I feel like cognitive neuroscience still has a very important place in this discussion. I didn't even really talk about it all, but I think that the best chance it has is not to think about these as totally separate fields or totally separate studies, but to get more sophisticated on our experimental design and how we can accomplish both in the same study so that they inform each other directly, not just like after the fact, because they actually wind up informing each other very poorly. It's almost like we're not even talking to each other at all, and that's a disservice. So I like this idea of integrating large scale, soft, lighter touch, but, you know, bigger goal studies, larger population studies with deep dive cognitive neuroscience.
So here's a question I think most people might have thoughts about. What would the role of funding agencies, such as the National Institute of Aging, to move the field forward and promoting innovation and optimization in the way that Dr. Collins described? Anybody have thoughts about how we do that through funding?
Well, I've obviously thought about that. Things are changing. I've been working in this area for about 20 years, and the first grant proposals that we submitted proposing optimization, the reviewers were like, "What are you talking about? You guys are nuts." And now we see a lot more enthusiasm from reviewers. And in fact, we did a look at the NIH reporter about a year ago, and NIH at that time had, across the different institutes, had supported about 500 studies using intervention optimization in one way or another. NIH funds a lot of intervention research, and intervention optimization is still not the dominant paradigm, but it's certainly not considered a fringe approach anymore. I think NIH has the opportunity to exhibit leadership, and there's certainly things they could do in terms of, if they want to, in terms of program announcements, funding announcements, and ways of setting up funding mechanisms that are a little more natural for intervention optimization. It seems like there's this expectation now. You get an R01 funded, you're going to develop an intervention, and you start from scratch, and at the end of it, you have a working intervention tied up in a neat little bow. And it would be nice if that expectation was changed, I think.
From the European perspective, of course, the funding for interventions is very critical, and longer-term funding, now said finger, we have been running it now 15 years, and the value seems to be growing when we really get all the data, the worldwide figures with 68 countries. I also thought back for the biomarker field, what is happening there in the future. Of course, now Alzheimer's field and the blood-based biomarkers, no one believed some years back that we will develop and find new biomarkers. We don't know yet what will be available. We are collecting blood, we have digital biomarkers. We may find something that really can help us to understand more about the mechanistic part as well. So that's what I have in my mind when we are designing our trials. We don't have yet all the biomarkers and measures, but we collect a lot of data that hopefully can be used in the future to understand more.
So I'll move on to the next question. How can we reconcile between the implementation of multimodal approaches as described by Dr. Kivipelto and Dr. Gazzaley, that seem to maximize outcomes and calls to understanding underlying mechanisms, such as the contributions of relevant components or features, which is more difficult with such complex, approaches. So how do we reconcile that, this implementation? Can we repeat that question? Yeah, okay. So how can we reconcile between the implementation of multimodal approaches as described by Dr. Kivipelto and Gazzaley that seem to maximize outcomes and the calls to understand underlying mechanisms? Let's skip the rest of it.
Yeah, I think all of us could speak to some degree, but these are like the two twin towers, right? Of what we work on, right? We want to help people. We want to do something meaningful. That's guides probably everyone listening to this. We're translational by this very conversation, and so outcomes are of critical importance. If we're not really making a difference, then what are we doing? But at the same point, many of us are scientists that have grown up learning and caring about mechanism, or even inspired just by the goal of knowing how the brain works in itself. Even if you're not making a difference, it's still an inspiration behind a lot of our work. And so reconciling those is really challenging. And I think my last comment about coupling deep dive neuroscience that could look under the hood, start manipulating, Linda's amazing approach to optimization can be also thought of an approach in some ways to mechanism, right? Where you can manipulate elements and see how maybe not outcomes are changing, but how what's changing under the hood. And obviously connecting what happens under the hood with what happens in the real world is like our ultimate, most challenging goal. So I like that question because it just returns us to, these twin towers of mechanism and outcomes, and they're connected, obviously, but it's hard to do both. They have, their methodologies have often been separated, and the more sophisticated we could think of combining them, the better off we'll be.
Yeah. I often get the question in the multi-domain finger model, which of the components can I say one that is more effective and what are the exact mechanisms? We don't know yet. We believe that you target several and then you can really target several key mechanisms and networks. So then you don't maybe always need to do so much for each of them, but it's kind of getting these positive circles in many different pathways. It can be cognitive reserve or vascular inflammation, different type of mechanisms. We start to have some clues with blood-based biomarkers what is happening there, but it's of course not yet totally clear. So I normally say we need to study more, but we have enough evidence, I hope, to justify some immediate actions when it comes to having the message that risk reduction, prevention is important, taking care of your brain health. So I think we can optimize the models when we learn more. And the adaptation, again, one size may not fit all. If you're talking about younger persons, midlife, older persons, those who have brain disorders, you may need to adapt the intervention in different ways. So I think both refining the studies, but also starting to do something on population level, I think is important.
I'm going to move on now to the audience questions. There are also some other questions from moderators, not moderators, but members of the panel. So and these came in the order in which you were speaking. So I'm doing them, in the order of the times you were speaking. So you'll see that there's different questions for different people throughout. So the first one is Aaron Seitz. Hope I'm pronouncing your name correctly. It is conventional these days for training tasks to be adaptive in some manner based upon participant performance. I'm curious, what are the critical elements that you see as key to an optimal closed-loop cognitive training experience? Further, what should be considered when designing adaptive experiences for diverse populations that may differ from each other in multiple dimensional ways?
Great. Thanks, Aaron, for that question. Yeah, there's no 100% answer to this, and it's still very much a work in progress. But I can tell you that we have been, I tend to think about it a little bit along the lines of how I presented in the slide, that the things that can be fed back are different sensations, but also different challenges and different rewards. And they're woven together, but they can be thought, they're not orthogonal, but they can be thought of as different levers that can be changed, and they have different effects on the person engaging. How to connect your decisions about guiding algorithms to change sensations, rewards, and challenges based upon the data that's coming in is, that's the art of the beast, and what we spend, sometimes years trying to figure out how to do so in a way that then, moves the needle in some manner. So, there's much longer discussion, but that's a little bit of how we think through. We, sort of put the inputs and those are the outputs, and then try to connect them. What we often discover is that we're wrong, and that what we might anticipate as the type of interactivity that, forget about making a difference, but actually that people enjoy or will engage in at all, is often wrong, and that people constantly surprise us by what they like and what they don't like. So my answer to your second question about diversity is really one of putting the end user, whether it's a patient or someone from a certain population, in our case older adults, into the design process and the development process. Because if you act as like some overlord that knows everything about the future and this population, you will be wrong probably most of the time. And so we frequently develop in a very iterative process where we build and then we test on that population, get shocked at what we find, and then rebuild. So it usually takes us 2 years of development before we start any trial. And then if we want to move to a different population, we are often back in the iterative development of then targeting that population and making the adjustments that are better for them. So hopefully that's speaks to that a little bit.
Anybody else want to add anything to that? No? Okay. So we have 2 questions from Todd Horowitz. I'm going to read them both because the second one's related to the first. Can we think about Adam's talk in light of Linda's talk? Are these gamified, closed-loop, full-body recording, interpretive, generative AI-powered interventions optimized in the way that Linda is talking about? Do we know which components are most important for effective experiential medicine? And Todd also said, similar question for Miia, do we know how important the various fingers are? So who wants
Maybe
to?
I'll answer before Linda, to set her up, because I know her answer is going to be better than mine. But I would say that this has been a 15-year journey for me and our group in this. And when we started, we were like really systematic about adding things, testing them, very mechanistic, very manipulating of small elements and understanding their impact. And maybe I've gotten impatient. I don't know. I have daughters now. I want to like do something important in the world before they're they're old. And so now very frequently I try to guide what we create here based on intuition, and I put in more factors than I have any idea about what their individual roles are now. And I just want to see that we could do something meaningful with them, both from a cognitive perspective and hopefully a real world perspective. And then we have a lot of work to do on optimization, pathways and mechanistic pathways, like Linda described, to really figure out what is needed here, what's not needed here. So that's how we've gone about development most recently, has been pretty aggressive in mixing things together that we believe, based upon our experience and our work, are going to have value when coupled together. That's the type of thing that may make some reviewers scratch their head and say, I don't get this. But if we're getting an outcome that's meaningful, especially in a well-controlled trial, it's meaningful. And then there's a lot of work to do to optimize. So I don't feel like they're in conflict with each other. It's just, a different style of, do you develop up by adding the things on, or do you build it and then deconstruct it and sort of understand it through reverse engineering? At least that's my thinking on it.
Linda, do you want to comment on that?
Yeah. So in general, I mean, I'm not really I don't work in the aging area very much. I'm a little bit of a carpetbagger here. Today, I've worked more in smoking cessation and substance use. But I usually don't recommend that people start by putting a bunch of components together, and which I realize, Adam, I'm making it sound less systematic than you have been. And then afterwards, trying to deconstruct the intervention. I'm always thinking about, instead of like a 5-year time horizon, more like a 10-year time horizon, because I would like to see us get set up so that we could, in a much more nimble way than we can now, be testing components and discarding ones that don't work and adding ones that do work. But before we do that, we have to know today what we should keep and what we should throw away. Sometimes, I shouldn't say sometimes, a lot, I get the comment, well, most is all well and good, but it takes too long. And I've started saying to people, it takes too long to accomplish what exactly? Because if what you're trying to do is come up with an intervention that will give you a significant effect in an RCT, and that's all you care about, then yes, most takes too long. But if what you care about is building a foundation for then being able to improve an intervention over time, for understanding the mechanisms that are operating within that black box, then I would argue it doesn't take too long. I would argue that it's the way to do that. And actually, once you get set up, then there are more efficient designs you can use that I won't go into here. And also, we're starting to work on kind of an overhaul of most that's much more Bayesian, that might be able to speed up the process a little bit. That's what we're hoping for. But in general, I guess I'm just much more start from the bottom and work up. But that's probably just different work styles as much as anything.
For the finger part, what is there? So the finger was designed to be quite pragmatic study. These are the components what you would recommend for a person if you want, not only for brain health, but as I say, there are many other outcomes as well. So that was the starting point. And then, of course, they are so much interrelated. Being physically active or during the group training. It is also cognitive stimulation, if not directly cognitive training, but these components are really linked together. So that's why we believe the package is very important. For all the people, they need to eat in order to be physically active and in order to be also cognitively active. So there is a synergy. On individual level, of course, we may know that maybe for some person it's more the sleep and stress, for someone else is diet. So what I recommend in my clinical work, think 5 fingers where you need to start with. So that's the optimizing or adapting in the implementation work where we are now working with, trying to find on individual or population level, maybe if there are some specific risk factors. And maybe the final one, there are maybe, as I said, new risk factors coming. So what we try to do now, as part of the 5th finger, cardiovascular metabolic, is taking also hearing loss and visual loss. Of course, if you can't hear and see, that's not good for brain either. So I think that's also expanding the model when new evidence is coming.
Great, thank you. So Mark Yankes, question for Dr. Gazzaley. Could you expand more on the closed loop feedback system? Does the system learn from each subject, previous training sessions, and adapt the current experience based on the current state, but also taking into account the subject's previous history? That is the experience adapted individually based on what the closed loop system learns from each individual through training?
That is how we most frequently do our closed loop designs, is that someone is engaging with it, the system is changing based upon their data. When they put it down and pick it up again, it is where it was before. So we often say if someone's at home, like say a 12-year-old in one of our trials, and they're using one of our games, and then their sibling picks it up, it would be just very different. Of course, it would then adapt to them. So that's how we have done it. But there's just so many so much potential here to do more, and that is where we're interested in what can closed loop designs do when you're looking at further history, not just immediate history. What can closed loop designs do when decisions, algorithmic adaptive changes are made, not just based on the individual, but on population data contributing to that. We have not done that, but there's a lot of potential. I'd also like to say that it's pretty unsophisticated in terms of how we do this adaptivity. We're using adaptive staircase algorithms that have really been unchanged for decades, and I believe that there must be more sophisticated approaches to adapting using machine learning tools, and that's an area that we're interested in. We've been meeting with machine learning experts saying, this is how we do it now. Does this just seem like the beginning of the alphabet to you? Like, where are we missing advances from your field of, high level analytics and machine learning that could make these closed loop systems so much more powerful? So I'd say we've been just the tip of the iceberg, and it already has shown great utility for us. We have a paper in Neuron where we showed that depending on what is adapted, you could get different outcomes. So it really is, the adaptivity really does make it a bit surgical in that it is the elements that are adapting that are putting the pressure on the system. And so you can this is the opportunity to direct where that scalpel is pointing and how hard it's pointing. But I think we could do a lot more. The last thing I'll say is our body brain trainer trial had 5 different closed loop algorithms going simultaneously because we were adjusting both physical fitness parameters based upon wearable data, and we were adjusting the cognitive parameters based upon performance data. And then we discovered that the closed loop systems interact with each other in completely, well, at least to us, unpredictable ways. So there's just like a ton to do to really get much more advanced on how we can apply this tool.
So Adam, can I just comment, if you're interested in intervention optimization, there are people working on, I don't know if you probably didn't commit my figure to memory, I wouldn't expect, but I did mention that there are, there's a different sort of type of optimization RCT that comes out of the engineering, the system identification experiment. And there's people working in that area, one more from the control, like building a controller type approach, and one more from the machine learning type of approach. Susan Murphy at Harvard is doing the machine learning stuff. And Daniel Rivera, who's a chemical engineer, has been working in behavioral science at Arizona State. So those are both really interesting areas that, as I'm listening to you talk, just seem directly applicable to your work.
Thanks, Linda. I actually took a screenshot of that slide and also made a note to myself to follow up with you and to learn from you and to find ways to work together. So yeah, so it was really very interesting. I think that there's lots to do in terms of optimization approaches that could run in parallel to the work that we're doing. So I'm really happy to follow up. Thank you.
I was thinking the same, and Linda, I saw your question about the optimizing, how we could do it in a more systematic way, also in the Worldwide Fingers. I would be happy to follow up and discuss this further. We have been doing it now in the Worldwide Fingers. We have a Worldwide Fingers loop, so it's kind of taking the lessons learned from each trial and try to use it when we plan the next trial. So we kind of optimize and adapt the protocol. We have harmonization guidelines to make it better and better, but I would love to discuss it a bit more, how we can do it even better.
And that would be interesting.
Great. Something's coming out of this for everybody. So this may be our last question. This is from Adam Turnbull. Do you have any advice for breaking out of the culture you are talking about getting a significant evaluation effect, that is, given the constraints of publication and funding culture? So how do you do?
It's maybe easy for me to say this since I'm tenured, but I would say all you can do is be bold and keep proposing stuff. Over the years, I've heard lots and lots of people say to me, oh, well, you know, I love these ideas, but I'm not going to follow up on them because I don't think I could get it through our review committee. And that just hurts my heart, because if everybody feels that way, then nothing will ever change. There'll never be any new ideas in science, not just about intervention optimization, but lots of other things too. So the person who asked that question, consider taking one of our trainings, and that will give, our trainings are focus on helping people to gain the skills they need to write successful grant applications. And remember, NIH has funded, 500 or more now studies using MOST, and review committees are starting to say to people who are submitting applications using the classical approach, you need to consider using MOST.
Yeah, I love that. Be bold, Linda. That's a great ending quote. I think I would just add to that that times are changing. We've been fairly successful, I would say, at Neuroscape, and we have struggled to get NIH grants for a long time, and things are changing now. We have 5 NIH grants, including a Roybal Center most recently. 2 R61s, an R33, an R01, and the Roybal Center, and these were just getting trashed by at least one reviewer not even 6 years ago. So it's not that everything's entirely different, but this field in general is arriving. I think there's been enough groundwork. We haven't answered all the big questions, which is why this webinar series is so great, but things are changing. It has been de-risked enough, I feel, that there is government funding available. So I just keep trying.
So with that, I'm going to turn it back to our NIH host, Melissa.
Thank you, Dr. Phelps. That was great discussion. So I want to close with our next steps. Webinars 1 through 4 are posted online, and this final webinar from today will be posted soon, as well as a summary report from each of the webinars will be posted. So thank you to everyone, especially the steering committee and all of our speakers and moderators who have really made this series really fantastic and informative. Thank you. Thank you for joining.